Hello, everybody. As you're coming in, welcome to our IPTOP webinar today, this morning, tonight, wherever you're joining us from around the world. And I'm really pleased that we have UC, who is speaking with us today on the really important topic of sex and aging and the role of physiotherapy. It's not something that I think we hear a lot about, but raising awareness about sex and aging is a really important part of what we do with working with older people. During this presentation, we won't be able to see or hear you, but you can ask UC questions through the chat if you use the button that says Q&A, and I will put those questions to UC at the end of the presentation. But I'm going to hand over now for the next 20 minutes for UC to tell us all about this really important topic. Over to you.
Fantastic. Thank you, Melanie, and thank you to your organization for inviting me to speak. It's quite the honor, and I am very excited to speak with you all about the very important topic of sexy time and aging and the role that us physios have in promoting sexual wellness for our patients as they age. And so one of the main objectives is I want you all to be able to describe one framework that you would be able to use and approach a sexual health assessment for an older patient. But at first, we want to have a little bit of background. And so when we're thinking about sexual disorders, I'm going to be speaking about it in a binary perspective between male and female, but also to understand that as these definitions have been made, they are continuing to evolve as we understand more about gender and sexuality. But when we're focusing on female sexual disorders, it is defined by, first off, desire as well as arousal. So depending on who you ask, the ISSWSH and the International Consultation in Sexual Medicine looked at it from two separate issues. It used to be combined as hypoactive sexual desire disorder as one, but then they separated it between hypoactive sexual desire disorder and female sexual arousal disorder. And they defined the arousal disorder between genital arousal as well as cognitive arousal. And then we're going to look at persistent genital arousal disorder, PGAD, which is much, much, much more rare condition. And then we look at it from orgasm and orgasm illness disorders. And then, of course, sexual pelvic pain, in which they call genital pelvic pain and penetration dysfunction. Now, in all of these conditions, for male and as well as female, we're going to see that they have to last for at least 6 months or longer. And the key thing to know is that people might be having these disorders, but they are not distressed by it. But it is the distress that makes this disorder significant, where intervention has to come through. And when we're looking at male sexual disorders, this is just a sample because the list is going to be a little bit more lengthier, but this is looking at ejaculatory disorders. So premature ejaculation, whether that's lifelong and acquired, as well as delayed ejaculation. And then here you'll see as well the conditions of delayed orgasm or anorgasmia, as well as ejaculatory anhedonia, as well as dyssynergia and retrograde ejaculation. And we also are going to include in some of these disorders erectile dysfunction. Now, what is important for us to understand about sex and aging is that the context is foundational. And what it's important for everyone to know, or the purpose of this slide, is that adults who have sexual dysfunction do not view themselves as healthy. And they want to talk about sex. However, they're rarely asked about it because as individuals age, their sexuality leaves them through society. So it's not just their own perception, but it's also the way society views them. And so the questions that we ask about their sexual function in their 20s is not the same questions we're asking them about their sexual function in their 80s. And we should be assessing it equally despite how they're aging, because people are still wanting to have satisfying and successful sex lives. And so what are some of those barriers to why we're not talking about sex with our aging adults? Oftentimes we've seen some of these come up. Some of our patients are thinking, are they healthy enough to have sex? Or sex is only for the young and, quote, beautiful, however that is defined. Or older adult sex is shameful or funny. It's just the dirty old man trope. Or they're too frail to have sex, or sex ed isn't necessary because they already know what to do, which is actually Not the case, because as we know, with learning and education, it's going to be a consistent and continuing ongoing process as we age. And as our bodies change, we need to gain more knowledge and understanding about how to move our bodies and engage in sex lives that are to be satisfactory. So when we're thinking about the factors that influence sexuality and aging, that's going to be diet, exercise. We're going to see a lot of issues with chronic illness, anxiety, depression, privacy. So, especially our adults who are living in nursing home or assisted living or group homes, the privacy is a major issue when it comes to their sexual function, as well as their mobility and what they have or have not been educated and what they can do with their physical limitations, as well as their cognitive limitations. But I want you all to understand that all of these factors that we're looking at that impact sexuality, these are the same factors that impact sexuality at 20 and again as we are aging throughout the lifespan. So they don't necessarily change, but they're going to be impacting us differently because of how society approaches older individuals. So what we know to be true about being sexually active is that it is, like I said earlier, strongly correlated with better health, and it's also highly related to partner availability, particularly when we're looking at cisgender women. So, cisgender men, it's highly associated with better health. With cisgender women, we're seeing that partner availability and openness to sexuality is going to be a big factor in terms of their sex life. So, older men aged 57 to 64, about 84% of them were sexually active compared to 39%. So, that drops significantly of those between 75 and 85 years old. And then when we're looking at women aged from 57 to 64, you're seeing they're sexually active at 62%. And when they go from 75 to 85 years of age, that drops down to 17%. And then also too, when we're thinking about the concepts of relationships and aging, like I said before, distress is the measure, and sexual activity is strongly correlated with a greater enjoyment in life. And so for women in between the ages of 45 and 64, we're seeing the highest prevalence of sexual dysfunction. And the biggest issue is going to be low libido, low desire. And then we're seeing followed by arousal and orgasm. And then, of course, the quality of their sex life. So, what's related to their quality of sex life is their feelings of intimacy and partner factors. So, what's important here that we have to understand, especially with the LGBTQIA plus community, is that there aren't any significant differences between cisgender women and men and the likelihood of them being sexually active, right? Who identify as being a part of the LGBTQIA plus community. But disclosure of sexuality can be moderated by any anticipated stigma, and that's going to be dependent on where they are in the world and cultural factors. But we also need to consider the intersection between ageism that this group will experience, as well as the heterosexism. So the assumption that they are married to a man or a woman and other identities that impact that intersection, such as ethnicity, race. So this does result in disparities that persist with no medical oversight. And so another thing to consider is that we need to make sure we're optimizing autonomy and privacy and avoiding barriers to express this gender sexuality. This is particularly important with aging adults because of the barriers to living with family, oftentimes the concealment of their identity, the estrangement. And again, in terms of access, this is something that is often seen as a missed opportunity in the medical community, because here is where we're seeing a lot of our patients falling through the cracks, especially our older patients, because we're seeing them not accessing care just in general for cardiovascular disease, cancer. And again, this is going to impact their sexual functioning as well. So when we're thinking about the menopause effect, it's important to understand the changes that are occurring during menopause for women, whether that's through the tissue function, muscle power, cardiovascular health, but also that decline in sex hormones that's going to impact them in a range of physical, emotional, and cognitive responses and appraisal. And it's also challenging in this phase because we're not sure sometimes is the impact of the sexual function mostly on menopause or aging alone. So this is a wonderful opportunity from a physiotherapy perspective to reassess their sexual health. And so this is a slide looking at the sexual history of menopausal women, looking at it from a biopsychosocial perspective. So biologically looking at their risk factors, but also the psychosocial factors that they're experiencing. But here's a summary of what that looks like, things that we want to consider. An early diagnosis of sexual disorder prior to entering the menopausal transition is going to significantly impact their sexual function postmenopausal, as well as the genital urinary syndrome of menopause, which is going to be the decreased circulation of estrogen through the system and locally through the genitals and the lower urinary tract. So you're going to see the changes in those tissues and their function overall, as well as mood disorders and other pelvic floor dysfunction that they're more likely to experience due to this. And one thing that we're wanting to think about in the aging and sexual response cycle for women is that with the decreased testosterone that they're also experiencing, you're going to see a reduction in libido and desire, which is already a high level, also one of the most common issues happening for aging women. And that's also going to be a decrease in their sexual thoughts and fantasies, decreased sensitivity to the erogenous zone, increased time to sexual arousal. That's going to be both cognitively and genitally, and then the decreased intensity of their orgasm and lack of concentration and fatigue. Now, for men, what we're going to see is the normal changes of sexual functions that occur can be with their erectile dysfunction, the intensity of their ejaculation, delay in ejaculation. And when we're seeing that decreased testosterone in men, we're also seeing that sexual arousal and time to orgasm has lengthened. So that can cause a lot of distress for people who are experiencing frailty or endurance issues. Their erections require more physical stimulation. There's finding them reduce frequency and durability, as well as the decline in their erectile rigidity, as well as their ejaculate volume and refractory period. But ejaculate volume is decreased and the refractory period is lengthened. And so here, one of the things that is the most common cause that we're seeing in ceasing of sexual activity for heterosexual couples beginning at the age of 50 and up is erectile dysfunction in men. And usually that's going to be associated with low self-esteem, performance anxiety, psychosexual stressors, as well as relationship problems. So when people talk about decreased sexual function in women and men, or heterosexual couples, usually that's going to be initiated by the man, not the woman, despite what we talked about in terms of menopause. So a new approach. So we know sex is great. Everyone loves sex. Sexual enjoyment is important. Satisfaction with their sex life, participation in sexual activity is positive for aging adults. When we're looking at this chart here, the study done by Ossai, Smith, and colleagues, they clocked sexual activity as being one of the best factors to reduce frailty and to improve the outcome or the probability of successful aging. So it's going to increase endorphins, reduce inflammation, increase physical activity. They're going to enjoy life. They're going to have better sleep quality, and it's going to reduce those depressive symptoms. So all of those are going to be addressing a lot of the factors that impact sexual function in general. So that is why it's going to be important for us to always ask about sexual knowledge and sexual concerns in addition to the medical and physical concerns that we're seeing in our patients. And we have to incorporate the sexual counseling in patients with chronic and long-term illnesses. So patients with hypertension, type 2 diabetes, arthritis. We want to encourage them to continue being sexually active, but that sexual activity is going to look significantly different than it did when they were in their 20s versus when they're in their 70s. So it's not about maintaining the same type of sexual activity, but it's still maintaining some sexual activity, sexual satisfaction, closeness, intimacy. We want to also be mindful of sexual orientation and relationship structure variation. And we need to make sure that we're assessing specific sexual behavior. So not assuming that everyone's having penetrative sex and not assuming everyone's having outer course or oral sex or digital stimulation. We need to specifically ask about their sexual activity. And then making sure that you establish community sources that can provide safe support for older people, particularly those with marginalized identities. And so when we're thinking about assessment frameworks on how we should ask or look at looking at sexual function for our patients. I know you all are looking at two very different frameworks. One is going to be the International Consultation of Sexual Medicine, their five-step algorithm for managing sexual dysfunction in men and women. And one thing that's important here that you all need to see is that what is mandatory is to get their sexual history, to get their medical history, to get their psychosocial history. A physical exam is not mandatory. It's only indicated if based on their patient's report. So for those of you who are not pelvic health experts or physios, pelvic health physios, simply asking about their sexual history and their concerns and having a referral base available for that patient so that you can refer them to and acknowledge that concern as something real, and that's going to help them thrive and diminish frailty, or the probability of frailty in their future is going to be very, very important. Another thing we need to understand or look at when we're talking to our patients is what are the social determinants that they are navigating in their life? What is the context of their life? What is going to be important in terms of asking them about, hey, what is it that we need to do to help you improve your sexual functioning? And it's not just a matter of getting them the right sex toy, but it could be about accessing privacy, safety, right? Sometimes the things that help sexual functioning is making sure someone has access to the proper dental care. They have access to managing their pain. What are the structural barriers that are keeping them from getting to proper care and addressing some of those other issues that they may have that will impact their capacity and their ability to engage in this part of their life? Another thing we need to consider when we're addressing sexual function is the biopsychosocial framework. That is going to be a core framework for patients to really identify what is the major driver in their sexual concern, and maybe making sure we differentiate the issues for them between the biological, the medical, the relational, what are the interpersonal components, and having your patients understand this and map this and show this to them. It's not just enough for us to hold this information, but sharing this with them, even giving them a blank chart that says, here, why don't you tell me what's going on in your biopsychosocial model from your perspective? And that will help them have a better understanding as to what is in their life specifically that could be impacting their sexual functioning. Another thing to consider is the trauma-informed care framework. And the reason why I'm bringing this up is that when we're thinking about the concepts of safety, trustworthiness, transparency, and we'll see this in a couple of slides, peer support, collaboration, empowerment, those are also key factors in having a successful sex life for a lot of your patients. And many of them have not had basic sex education. And so starting from a place of safety, because education is safety, transparency, trustworthiness, communication, those are key factors for having a satisfying and fulfilling sex life that a lot of your patients haven't mastered or have not been taught, but they're willing to learn. And so here are some examples of a few questions that you could ask some of your patients regarding your sexuality. Particularly the question of, have you noticed any changes in your sexual enjoyment or your sex life? Does this change concern you? If it doesn't concern them, you can move on and you can give them resources if they want. But these questions open up the door and allow them to share with you. Even if you don't have all of the resources to help them, you can at least refer them to someone that does. And here's another example of some of these general suggestions for your patients is planning the sexual activities, taking their pain meds prior to, ensuring rested and relaxed states. For your patients who have stroke or movement issues, putting them in positions where they can be supported posturally, educating their patient's partner about different positions that will be optimal for them can be really, really helpful. And encouraging specific aids, as is saying here, to help your patient have a sex life that is going to help them feel empowered and happy and affirmed. Another thing that is very important is that we measure everything. We measure pain, we measure anxiety, we measure fear avoidance. We also need to measure their sexual function. We need to measure their distress. And here's an example of some dimension or some assessment tools that are very effective. Everything from orgasm to ejaculation to sexual satisfaction to sexual desire, knowledge, as well as erection. So these can be helpful tools, particularly if you don't want to necessarily start your patients with this type of measure. You can give this to them once you've established trust or you've done this after a few visits. So from a physical physiotherapy perspective, a lot of the things that we want to kind of summarize is that yes, PTs, we do the patient education, but we need to do patient re-education, sex ed for our patients, global muscle training that's going to address a lot of the issues that you're seeing in terms of the physiological changes that happen with aging. And then the pelvic floor muscle coordination training. So, depending on what the issue is, they may need strengthening, relaxation, coordination using assistive tools from eSTEM to biofeedback, as well as neuromuscular re-education, pain management. And all of these interventions are going to be based on the diagnosis, what's happening at the tissue and the context. And then from a gold standard treatment perspective, multidisciplinary care is key for patients who have sexual dysfunction. So, for example, here, a patient with ED, a lot of the treatment approaches can be from everything from directed guided masturbation to pelvic floor muscle upregulation or downregulation, depending on what the issue is, sex re-ed, anxiety reduction, medications, oral, suppository, injectable, even a vacuum constriction device, or an implanted pump if they so choose. So when you're thinking about for your patients, quick ways to frame them is for them to value variability as they age, not to accept it, but to value it and to create a space where they can be open-minded and understand what needs to be honored and acknowledged. Is it their ED? Is it their genitourinary symptom of menopause? Is it pain? Is it their desire for connection? And using the concepts of sensuality versus sexuality. Is it that they just want to be touched? Is they want to engage in those senses? How can that be elevated for them so they can have a pleasurable sex life? And then also using pleasure for them to challenge any cognitive distortions that they may have in their own age stereotypes or gender norms or whatever they feel is going to be needed for them. And then also for them to disband that sexual play hierarchy. So for a lot of patients, particularly male patients who have ED, they have this gold standard. They're like, I want, we just went through the Olympics. They want the gold. The gold is penetrative sex, a rigid erection. And sometimes that may not be realistic. But instead of having pedestal type sex, you want to have a collaboration system. You want to think of it as a buffet. What sexual activities, what activities can we pick and choose from today? No one is getting a gold, silver, or bronze medal. That doesn't exist when it comes to their sex life. You want to build that sexual intelligence and that openness to variability because that is what's going to sustain them into their 90s and the hundreds if they so choose. And finally, they need to reframe and optimize arousal and satisfaction. So they have to triage their communication with their partner. So using that trauma-informed perspective, they want to establish trust and safety, which builds transparency about their goals, their stories, understanding and centering both of their physical limitations, their issues, or their concerns or shame. And then they need to cultivate pleasure within that space. So this is where they have that shared decision making with each other, collaboration, that mutual support and empowerment. And that can create a space for exploration and enjoyment. And that's it.
Thank you. There's lots and lots of different ideas and so many aspects of the
Yes.
topic.
Yes.
For people that have just sort of seen all of that and then are now feeling a little bit overwhelmed, where where do you suggest that people start?
I suggest that people start by simply just asking your patients, getting into the habit of asking all of your patients, are they noticing any change in their sexual enjoyment or their sexual function? And is that concerning to them? Is that distressing to them? And when you start with that, that is a place where you can simply asking the question validates it for your patient as something that's medically important, especially for your patients who have chronic illnesses, who may have shied away from sexual function because they haven't viewed themselves as sexual. But when your healthcare provider is asking the question, that's a very important and powerful validation that a lot of our aging patients need.
Mm.
And
And
that's
so
a very simple way to start.
it is a simple way to start. And I'm just like it sound like that idea of that multidisciplinary care is important as well because there's potentially orthopedic or neurological considerations as well as the pelvic health considerations. So do you have any thoughts on how we can all work together in a collaborative way that sort of, by the time people have multiple health practitioners, it's a lot to manage. What can we
Absolutely.
do to help that in the background?
Yeah, in the background, I always tell my patients, I always start with my patients and giving them this idea that they need a sexual health dream team. And really understanding my role as their physical therapist is I'm going to give them the education and the information, and I'm going to help them with their power, their muscle strength, right? Their tissue tolerance. But then they may need some Balta for their pain or their anxiety. And that's going to be from the person that's part of their dream team is their primary care provider, right? So they're going to need that referral. And they're also probably going to need some acupuncture to help with some of their chronic pain issues. And that's going to be part of it too, because that'll help them build the cognitive bandwidth for engaging in any type of pleasure play. And then they may say, oh, you need to go see the urologist to make sure that you get your overactive bladder medication that will help so you won't feel your bladder won't feel so active when you're engaging in sexual play. And just keeping it simple for them and saying, okay, so here's how your body works. Here's what I'm going to do. Here's all the people that are going to help you get there. And here's how you want to work together for them in that framework. So
Mm.
empowering them by educating them in that space. Like sometimes I even do a body map and point to the bladder and say, you're a urologist, right? And say your brain and their acupuncture. But that's a great way to do
Mm.
that. And then from a provider end, I think it's important to have established friendships, collaborations, colleagues. We go to all these conferences, talk to each other outside of our profession, within our profession, and keep a list of people that say, you know what, here's a great person who I know is going to be really great in working with you with your urogynecological concerns or your colorectal concerns. And
Mhm.
then really having a list of free resources, so YouTube, podcasts for some of your patients that like to watch and listen, kind of have a running list of resources there that they can quickly and quietly in their own privacy watch and take it in.
And so that question of resources leads me to another question, which we probably is our last question for the session,
Mhm.
is really for, for people wherever they are around the world. Like you had some frameworks there. It sounds like that there is some sort of international bodies that are
Yes.
sort of dedicated to this space. Where can people go for reputable information beyond this webinar, wherever they live in the world?
Absolutely. The International Consultation for Sexual Medicine, they are an international body. The ISSM, the International Society for Sexual Medicine, as well as the European Society for Sexual Medicine. I think they just had their annual meeting in Porto last week, in Porto, Portugal last week. Those are going to be ISWISH, the International Society for Sexual Women's Health. That's based in the US, but they collaborate with ICSM and ISSM. So those are going to be the bigger sexual health um, resources. The World Health Organization has beautiful resources
Mm-hmm.
as well that I really appreciate and reference often.
Mm-hmm. So it sounds like there's a lot of freely available information out there.
Absolutely.
Yeah.
Absolutely. And if you want something like TED Talks, Esther Perel's work is excellent. She has brilliant TED Talks that can be accessed free, and they speak to a wide range of
Mhm.
individuals.
And you said YouTube and podcasts for
Oh, yeah.
people.
Yes,
What are the
yes.
ones you recommend?
Yes, I really like so depending on your age groups, right? So Hannah Green is a young individual. She has a colonoscopy, or excuse me, she has a stomy bag, and she is a young sex educator based in the UK, and she has a great YouTube. So that's good for individuals with disability who are younger, who want someone who has this, you know, vibey energy to her. There's a wonderful sex educator named Shan Boodram, and she goes by Shan Body or Shan Booty. And she does really great interviews on sexual health and wellness. Like I said, I really like Esther Perel and Emily Nagoski. She's international author on sexual health and
Mhm.
medicine, and she has some
Great.
YouTube as well.
Fantastic. Thank you so much for sharing your knowledge on this topic with our IPTOP audience. It's been a really interesting considerations that we need to make, and there's so much behind that question of how things are going and have things changed, which is such a big part of what we do working with older adults around all of their health and wellness. It's how are you? What's changed? How does that make you feel? And so asking about sex and sexuality is another part of that consideration that we need to keep in mind. So thank you so much for sharing your information with us tonight or today,
Thank
depending on
you
where
so
you are.
much. Well, thank you so much. I
Thank
appreciate you
you.
all.
Yeah, we'll just call the webinar to a close. Thank you for coming.
Thank you.